Well, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School, and welcome back to another Computer Connect. Now, the stethoscope is something that we almost have in our pocket for sure, in our lab coats, and use on our patients, perhaps to listen to their heart, maybe listen to their abdomen. What do we do with that information? Well, Dr. Larry Brandt, one of the true masters of gastroenterology and one of the renowned educators, at least in my 40 years of being in the field, expounds on the use of a stethoscope to further evaluate for diagnostic evaluation of gastrointestinal and hepatic disorders. Dr. Brandt is a student of history, but really goes back to some really very erudite comments looking back to put these things together. Let's start at the esophagus. Well, certainly the cervical auscultation begins with positioning the stethoscope over the median line of the cricoid cartilage. The Germans had evaluated and talked about certain sounds as the fluid or bolus moves through this area in the epiglottis or laryngeal elevation, and the contraction of the pharynx leads to some sounds. In the German literature, the terms der Sprechgeräusch and der Spritzgeräusch describe the squeezing of the upper esophageal sphincter and its squirting type actions. The ability to do this, and I use this at the bedside, is if I put my finger on the cricoid cartilage and then my stethoscope on the upper abdomen, the area of the EG junction, and I have the patient swallow a bolus of water in the recumbent position, and swallowing the liquid typically will be heard by the cricopharyngeal elevation and then a splashdown sound that you hear in the abdomen about 2 seconds later, and this tells me that the transit is normal. I've used this in a bedside evaluation for patients that may have esophagogastric outflow obstruction, certainly in evaluation potentially for patients with achalasia, and some of my patients as a prelude to further testing with time bear and swallow or endoflip for post-achalasia treatment. But it's a bedside test, very easy, no cost, no radiation. And obviously, there are digital acoustic recording techniques that allow this to be a little bit more perfunctory, but there are some things that will also potentially be delays in the transits, and this would be a Zenker's diverticulum or a mid-esophageal traction diverticulum. Again, these are things that you would anticipate would have a side swipe for with liquid bolus transit. So the esophagus to start. With the stomach and the duodenum, well, the gastric emptying, when it's impeded either by obstruction or neuromuscular disorders with gastroenteric diseases, certainly can create what was characteristically described as a succussion splash. This, again, should be performed if you're using a succussion splash when the patient's really not had anything by mouth for several hours. The volume of the ingested or secreted fluid to produce this splash is really not well known or characterized. But certainly, it's a very simple thing: putting the stethoscope over the stomach area, and you're sloshing back and forth. You can hear this succussion splash. This may also be evident when patients have compression of the duodenum between the aorta posterior and the superior mesenteric artery, known as SMA syndrome. So normally, the SMA transits off the aorta, and its angle is largely determined by a pad of fat. This averages approximately 45 degrees. And when that fat is reduced by severe weight loss, the angle of the SMA takeoff is diminished and obstructs the duodenum as it transits up towards the ligament trites. This was first described, as you may recall, back in the Vietnam days, where the patients had body casts and profound weight loss associated with that. So again, SMA syndrome, potentially diagnostic by a succussion splash. How about the small intestine? Well, the small intestine is obviously a distal propelled peristalsis. But Dr. Brandt talks about a very interesting technique of putting the earpiece of two stethoscopes and determining bidirectionality of which way the peristalsis is going. Just shows how you can be detailed in the evaluation of this. It doesn't really have so much pathologic implications. But normally in a small bowel obstruction, you do see a hyperperistalsis, so increased with obstruction. So higher frequent pitch sounds, and then this obviously tends to diminish over time as an ileus develops, and certainly you can hear a succussion splash if there is some type of formidable obstruction. He points out that prior to a colonoscopy, especially in an older man who's not able to provide a good history, we should evaluate the scrotum in particular to make sure there's not a hernia with a small bowel protruding out into the hernial opening. And again, peristalsis may be heard over this area with a herniated intestine. Obviously, should be reduced, or again, be aware of this before you start introducing colonic scopes and certainly with air. I might add one that wasn't mentioned by Dr. Brandt, one that I found rare but invaluable, was in the setting of GI bleed. Or GI bleed obviously creates it's a catharsis that develops with blood in the gut. Hyperperistalsis we see uniformly in patients with upper GI bleed, significant upper GI bleed. But in the patients that are immunosuppressed, particularly on steroids, and I've seen this in a transplant patient came in with an active GI bleed. I listened to the abdomen. There was no hyperperistalsis. In fact, the abdomen was quiet. Percussed over the liver, there was a little bit of loss of dullness in that area, suggesting intraperitoneal air. In fact, we did an X-ray rather than an emergent endoscopy, and the patient did have, obviously, free air in the abdomen. The patient went to surgery, not to endoscopy, which would have clearly been the wrong decision had we chosen the latter. But the colon. Well, the colon doesn't normally produce bowel sounds that are frequent enough to be appreciated on a routine kind of casual exam. In the presence of constipation, Dr. Brandt notes that the sizable amount of stool, and particularly in the distal colon, you can get a sound of the stool peeling off the mucosa, and this is appreciated by auscultation with gentle palpation and quick release of your hand, and they're performed simultaneously. This is called the Finicetto sign. That was news to me, but one that was an interesting new approach to use of the stethoscope. But the liver, well, when a lesion in the liver is well vascularized, and particularly we see this with hepatocellular carcinoma, cavernous hemangioma, the shunting that you may see with hereditary hemorrhagic telangiectasia, typically you can hear an arterial bruit over the lesion. And Dr. Brandt makes a very adroit examination where, in particular in patients with cirrhosis, he takes the stethoscope using now the bell and repetitively lifting, replacing it adjacently over the entire area of the liver. And he says in his experience using this technique prior to some of the radiologic imaging that obviously would be following, lesions as small as 2 centimeters in diameter have been evident just by this exam. One that we perhaps remember, if you're old enough to remember, with physical findings of physical diagnosis called the scratch test. This involves a maneuver that is used simultaneously to, with auscultation, evaluate the size of the liver. Very simple. The diaphragm of the liver is placed in the abdomen, typically starting in the right lower quadrant. And you scratch with your finger as you move up, with single finger upward, parallel to where you expect the liver edge. And when the liver edge is reached, the sound of the scratch transmitted to the stethoscope is amplified with the increased intensity. This is particularly helpful perhaps in patients where the abdomen is distended, perhaps maybe the patient's too obese or too tender for evaluation or palpation, or if the abdominal musculature is tense or rigid. So again, things that you can hear with the liver and maybe something that's quite helpful. If the patient has an abscess or a bleed, a subcapsular bleed, sometimes as this abuts Glissen's capsule, you can get a friction rub as a presage to capsular rupture, and this may be something that you can, again, hear with your stethoscope. Of course, the classic hepatic friction rub is seen with Fitzy-Curtis, which is the gonococcal perihepatitis and so-called violin strings that associate the liver capsule and the peritoneum. With portal hypertension and the formation of collateral circulations, the so-called Crevelier-Baumgarten syndrome, this may show with prominent veins along the umbilicus, sometimes giving the appearance of the caput medusa. And this, with the sculptatory findings, leads to evidence of venous hum. If you palpate this dilated vein, then you may actually get a palpable thrill. So again, something you can have both with your ears and with your fingers. How about vasculature in the stethoscope? Well, narrowing of an artery can produce a bruit. Typically, the bruits in the abdomen are reflective of bruits in the aorta, splanchnic vessels, particularly the celiac or SMA, and the renal arteries. The presence of a bruit, however, doesn't necessarily imply that it has pathogenic significance, with the potentially a couple exceptions. One is the diagnosis of median arcuate ligament syndrome, or celiac artery compression syndrome. This requires a very special maneuver that Dr. Brandt adroitly points out. And this is a differentiation from the stenotic celiac artery because of atherosclerosis. So the bruit of median arcuate ligament syndrome increases during expiration as the diaphragmatic compression on the celiac artery is more pronounced in this phase of breathing. And so this is the only situation which an abdominal bruit decreases with inspiration and increases with expiration. This is particularly important when you send that patient for a CT angiogram or a conventional angiogram, where the radiologist should be instructed that this is something to perform, because if improperly done, or the patient, his or her holding their breath, diaphragmatic impingement will be less intense, and you may not see as well the diagnostic evaluation that you might see otherwise for celiac artery compression syndrome. The other area they'll listen to is over the splenic artery, and this may be a bruit in a patient with a splenic artery aneurysm, a pseudoaneurysm, or perhaps with a pancreatic cancer. And as that cancer wraps around the artery, again, these would be things that implicitly would see on a CAT scan, but something that you can pick up in a prelude, perhaps just by using a good physical exam. So we come back to the point that the stethoscope can be really very much a more uniform application of a better diagnostic evaluation. Does several things, though. One, it implies a physical contact, endearment, and an engaging warmth, perhaps, to the patient, but allows us potentially, by using our ears, a way to expand our diagnostic acumen. The evaluation of this really is really exponential. It's not just a physical exam, but done adroitly and with expertise. A physical exam can be the art of obtaining the right diagnosis, correct, expanding our ability to interact with the patient and our diagnostic acumen. Thank you, Dr. Brandt, for teaching us and refining the art of a physical exam, now using the stethoscope in gastroenterology. So please, when it's in your pocket, take it out. Look at this, and we can do better. Dr. Brandt, you're the best. Thank you again for your wonderful expertise, and I think you all will find these points very helpful. Next time you take your stethoscope out. Dr. David Johnson, thanks again for listening.